Next presenter is Devaki Nambiar. Devaki is now with Public Health Foundation of India, but has a long career in public health. And she has done her doctoral degree from Johns Hopkins University on health behavior and expert in qualitative research. Over to Devaki.
Thank you, Dr. Kanjilal. Can everyone hear me? Please nod. Okay. Great. So it's really a privilege to be here at this session on community action in the context of UHC. I'd like to say I'm particularly delighted to share the podium with Professor Sundari and Mr. Kano, whose work I really admire, and other colleagues whose work I'm getting to know. What I'd like to present today is a pilot study on the scale-up of community action for health. We did a realist evaluation of the Mithanin program in Chhattisgarh, India, which many of you may already know about from Dr. Sundaraman's work and other contexts. I'm joined in this work by Dr. Kabir Sheikh, Namrata Verma, and our field coordinator, Kaveri Myra, who are in the audience. You can wave. And what I hope to do in the next 10 minutes and no more, hopefully, because that sound is god-awful, is to tell you a little bit about what is actually a very small study and is going to become a much larger project. So to start off with, definitions, that's already a place where you get a little stymied. When we're looking at community action for health and you're trying to add the element of scale to it, there's often a major trade-off in terms of ladders of participation and scales of impact. And so you can really run the gamut of things that are community-based interventions, where if you use something like Arnstein's ladder of participation, it's actually very tokenistic involvement of communities, but it can be done at grand scales because the beneficiary is an entire nation or an entire state, as contrasted to community-led interventions, which are often necessarily very much of a small scale, but community-driven and led. There are many other examples in the country and other jargon, what Raymond Williams would call keywords, of definitions of community, like communitization in Nagaland, community-based monitoring, also things like intersectoral mobilization of communities, examples of which here are just illustrative, but from Sham we've seen there are examples in Karnataka as well. And very often there is this trade-off of scale and of the level of community participation, and also other elements of how you actually systemically run or engage communities or run community programs. And so going through an initial review of the literature brought us to the community health worker program in Chhattisgarh, which is the Mithanin program, started in 2001, right on the heels of the formation of the state. And by 2003, comprised a cadre of 53,000 community health workers in the state. Now, that kind of scale to be achieved in that period of time is really quite extraordinary. And you're looking at community health workers who are not only members of the community, but also engage with other community action processes. So we thought that was very interesting. And so we went there and tried to talk to the people who were involved with the running of this program. And to be able to evaluate or to understand better this program, we turned back again to the literature, where we found that one of the key things, for instance, what Susan Rifkin has said in her review work of community action in health, is it's really important to know what works, for whom, under what circumstances. And it's quite opportune that she said this quite literally, because quite literally, there is a methodology that's been developed to find out what works for whom, under what circumstances. And this is called, it was initially called realistic evaluation, but that, I think, didn't fly well with the inventors of the term, Pawson and Tilley, and those who applied it. Now it's called realist evaluation. But what they contended was that contexts matter a lot, and it is in those contexts that mechanisms lead to outcomes. And so when you're looking at causal explanations of even something as complex as community action in health, you have to pay attention to these things. And I'm not going to go into these examples, but there is an extensive and growing literature on realist evaluation to look at a number of health systems factors, including work that's been done by IPH and recently published. So we undertook to understand the mechanisms, contexts, and outcomes associated with the scale-up of community action for health in Chhattisgarh. We went there and spoke to the people there and realized that, as is indicated in the scale-up literature, community action in health at scale doesn't just sort of arise. It has to be sort of handheld. There have to be groups, resource persons that help take things intentionally to scale. And we discovered that the entity in Chhattisgarh that's doing this is the State Health Resource Center. It's not the only entity that's doing this, but it's one of the main ones. And so we refined our research question a little further and decided that we wanted to look at mechanisms, contexts, and outcomes associated with SHRC's roll-up of the Mitanin program in the state. And so we undertook 4 general groupings of methods to try to undertake our realist evaluation. They include policy document review of something like 43 different policy documents. We observed 5 different events in different districts in Chhattisgarh. We conducted in-depth interviews with different types and levels of practitioners across the state. And so it bears mentioning that we spoke to people who operate at the state level, those who operate at the district level, and those who are at the sub-district frontline, so Mitanins themselves and their trainers and that kind of thing. We also had focus group discussions with Mitanins and also with VHSC meetings, members of VHSCs, which included Mitanins, that were underway when we visited. So these are our findings. Chesterton has said, I was trying to think of a neat quote to sort of encapsulate what we found. And he said, Chesterton says, the simplification of anything is always sensational. So with that caveat, I'm going to try to simplify some of what we found and encapsulate it. So contexts. We found that there were a couple of important contexts to bear in mind to understand the Mitanin program in Chhattisgarh. I will focus on the new statehood of the state itself, which seems rather obvious, but is no doubt very important. We found that the state of Chhattisgarh created a sort of political opportunity structure for institutions to emerge that cared about scale and that also could be comprised in a different manner than other institutions. And so that, as you can see, this government official saying, we needed an institutional framework. We felt it could not be solely government or solely civil society. That is how SHRC was born. And so it is this sort of civil society, governmental mix of an institution, and that gives it a lot of its potentiality by way of mechanisms. So see, I'm really rushing through this. I hope not to over-sensationalize you all. Anyway, the mechanisms are many, but I will focus on this idea of integrating technical and social expertise. We found that in the way that SHRC was marshalling community action for health, there was a very deliberate and strong emphasis on combining technical capacity to disseminate health information and encourage health promotion with the idea of social mobilization. And so it happened that, in fact, the people in SHRC and in the grassroots levels were people that had social mobilization experience. For instance, this Swasth Panchayat or Healthy Panchayat fellow, who had worked in the water, forest, and land movement, and then later joined SHRC, seeing its merit and wanting to extend his role. But the way that this is interpreted is different, obviously. People in the government see the technical role of SHRC being very important, while you see someone who was in SHRC in early years saying that that social piece was absolutely essential. Oh my God. So now looking at outcomes, one of the outcomes that we thought was important to mention is the fact that it's lasted for a decade. And there have been positive evaluations of the program, so much so that there is a 40-point reduction in the IMR over a 9-year period in the state. Breastfeeding has increased significantly. These are not small gains. These are major gains. What's more, if you talk to Mitanins, they themselves express surprise and delight at the fact that they thought the program wouldn't last so long, but it did last 10 years, and it's still going. An SHRC leader said that the size actually gives it protection. And so here we see that community action for health at scale, the size also matters. And so that's an important piece also of our findings. So again, this is an overall view of our findings. We have a report coming out, so we ask you to look out for that. Just really quick wrapping up with your permission.
Sure.
We found something that's very obvious to everyone, but it bears mentioning again that one size does not fit all. And that even at scale, local context matters, mechanisms evolve, and outcomes vary. And again, I was looking for like a good quotable quote for this. And I couldn't come up with anything in my quick Google search, but I thought of this. If you want something everywhere, it will be the same nowhere. And I think that was one of our key findings in Chhattisgarh. That's very important to understand, particularly with community action in health. And it bears mentioning further that we need to do a lot more research in this area And of course, I add this to that last note. This was a short-term pilot study. We'll be doing a lot more work in this area using the methodology of realist evaluation. There are different issues that we didn't look at. There were different languages that we couldn't speak. And so there's certainly a great deal of more work that has to go into this. And with that, I'd like to thank my research team, the Governance Hub, our study participants, and you all. Thanks.
Thank you. Thank you, Devaki.